In 2023, a National Academies Committee was tasked with identifying essential healthcare services for women related to intimate partner violence, or IPV, during normal conditions, determining whether those services differ during public health emergencies, and identifying strategies to better sustain access to the essential services. The committee held 3 public meetings to hear directly from experts in the field, as well as individuals with lived experience.
As you can see from this image, there's great inconsistency in the prevalence of both IPV perpetration and IPV victimization. And this is not surprising, right? Folks are using many different definitions of what is an intimate partner, right? Also, what is intimate partner violence and what measures are we using to assess these things? So it's almost like looking at apples to oranges here, which is quite frustrating.
Well, we found that for a lot of our patients, having the quote unquote cover of the hospital made them more likely to access that support. So they can just say, oh, I have an appointment at the hospital. And in some cases, we had patients who were receiving counseling services on site, and that abusive partner may even have accompanied them, and they're waiting in the waiting room, and they have no idea that these are the services that person is accessing. You know, if we go back to that Maslow hierarchy of needs, if you don't have a safe place to sleep, if you don't have food in your belly, if you don't feel safe where you're at, there's just, these services that are critical and necessary can seem superfluous to that hierarchy of needs that that person is experiencing.
We work well with the Chung Ling Indian Health Services here. They refer victims here. I provide I used to provide trainings to the security on a quarterly basis. But since COVID, I haven't been able to do that. We refer clients to them. We're able to work with our sexual assault nurse really well. And I commend the emergency room staff.
I think there's a lot of solutions within our communities that are being generated in our communities for the problems that we're looking for solutions for. And so I'm grateful for the time and that you asked us to present. And I just encourage you to continue to look for those solutions within the community, because I really believe that they're there. We have a lot of strengths that are still here that we can learn from and that we can take advantage of.
Informed by the experts and individuals they heard from, as well as research and internal deliberations, the Studies Committee produced a consensus report in 2023, Essential Healthcare Services Addressing Intimate Partner Violence, that made clear recommendations for leaders of healthcare systems, federal agencies, healthcare providers, emergency planners, and those involved in IPV research. Various digital materials were also produced to help audiences explore content in a user-friendly manner. Post-release, the committee held a webinar featuring moderated discussions about the report.
Many of the women said, they definitely wanted healthcare providers to take some responsibility and actually bring up the topic. But they also wanted us to understand how difficult it is to disclose. They may not be ready to disclose. They may be afraid to disclose. But what they did say is, even if we don't disclose, give us the information and resources anyway. I can then use that information on my time and on my terms.
And so when I implemented the lethality assessment program and adopted the nurse-led model, I included training for the emergency department nurses. I actually did that in Wake County as well as in Durham County. But here in Durham County, I partnered with the Durham Crisis Response Center, and together we did training for our nurses. And once patients were screened for high-risk IPV, our patients were supported by Durham Crisis, and that provided a warm handoff to receive those services to ultimately prevent injury and death. I think having Durham Crisis as well as Interact, when I did it in Wake County, be present to do that education, it really helped people understand that it's just not nebulous.
If health equity is an afterthought, then it won't be equitable. It has to be done during the blue sky period, like everything we need to be thinking about equity from the beginning. And so even when we're thinking about, like, as one example, when we're thinking about language equity, right, like we need to be sure that all of the services are available in different languages, and not that that's something that we think about during an emergency.
Equality is important in our planning. We all have preconceived notions, and nobody goes into the planning process looking to exclude this group or that group or any group, for example. But by practice, we most of the time do. And I think healthcare coalitions really need to embrace that a wider berth of partnerships to include these high-risk groups that are most prone to IPV, and make sure that they're part of the conversation before, and definitely part of the response process during, and obviously in recovery and after action.
IPV advocates are frontline workers, sexual assault advocates are frontline workers, and things that are being distributed to doctors and nurses must be also distributed to our IPV advocates.
I'll never forget one story when I was working with an FQHC, and I asked them, okay, well, you've done your business continuity planning, right? So you understand what your essential services are. And the response was, well, all of our services are essential, which is a fantastic statement. However, during public health emergencies, you cannot provide everything and you have to prioritize. So I think moving towards understanding who, how, and when you go, right? And that tiered approach is fantastic. That's described in the report.
Just being able to have all the implements and supplies and equipment needed to provide quality and passionate, empathetic, sexual reproductive health care is so important to this work. And so
I think it's important to include an understanding of what the role of first responders can be, especially when it's specific to IPV. Look at what some of that intake and assessment process might look like, but then also training for first responders about evidence protection or about specialty services like sexual assault forensic exams. And if you have that opportunity to bring together a panel that included victim advocates, that would really expand out the understanding at a local level, and quite feasibly at a regional level, for what the different options are for service in your area. So I would absolutely promote that those victim service organizations should be included with more exercises. It's an opportunity for partnership and an opportunity to learn about the different services that they provide.
Access the report and additional resources about this topic at nationalacademies.org/intimate-partner-violence.